Thank you, Antonio. Thank you for coming. Thank you, Tesaro, for inviting me. What I'm going to present in the next meeting are the emerging treatment. What is changing in the treatment of platinum-sensitive patients? My disclosure. So, ovarian cancer remains the 7th most common cancer in women, and unfortunately also the 7th most lethal cancer in women. Also, it is the first cause of death among gynecological malignancies, so it is a great burden of disease. If we look at treatment of ovarian cancer in the last 40 years, you will see not an exciting picture. Because in terms of increase of overall survival, we simply increase overall survival by 8%, which is not an enthusiastic number, but something is changed really. We are able to increase the live longer duration of our patients. Our patients live longer. We increase the percentage of patients who live with disease at 5 years, but they are still alive. In other words, we transformed an acute disease in a chronic tumor, thanks also to the arrival of new drugs. But the natural history of disease is what you see in this picture. The natural history is a continuous appearance and disappearance of tumor. And the more the disease increases, the more time passes, the lesser is the time interval between one recurrence and the other. And unfortunately, the lesser is the possibility that patients still respond to chemo. Until now, the strategy that was used in patients who recurrence at the end of chemo was the watchful waiting strategy. I mean, simply we wait for the next recurrence of disease. But literature data suggests that this period is longer than 5 months in platinum-sensitive patients or less than 3 months in platinum-resistant patients. But the real question is, how does our patient live this period? If we look at this important analysis, we see that most part of our patients, platinum sensitive, responding to platinum, at the end of chemo still experience several symptoms related to the disease, but also to chemo, I would say. They experience lack of energy, they experience pain, they experience stomach swelling. But also, and probably it's more important to us, they experience a great psychological burden, particularly related to the fear that the disease could appear again. How all these aspects impact of health system? This abstract was presented during this ESMO. It is a very nice analysis in more than 1,000 patients with platinum-sensitive recurrence, suggested that 30% of these patients receive continued admission, ER visit and inpatient admission. And in most parts of cases, this is due to the occurrence of a new recurrence of disease or in such a way symptoms related to disease. So, in other words, what we are looking for, what the research of the last year is looking for, is something which is not chemo, which has no side effect of chemo, which is able to maintain quality of life of our patient, but particularly is able to maintain disease under control. In other words, we are searching for a maintenance treatment. Basically, the research of the last 5 years has produced 2 different types of maintenance treatment. The pure maintenance strategies of PARP inhibitor and the strategies of anti-angiogenic agent, which is quite different. We will see it more in detail. In this moment, we have 3 PARP inhibitors developed and licensed in ovarian cancer. 2 of them, Niraparib and Olaparib, has been licensed for maintenance treatment. Niraparib has been licensed in the United States for the maintenance treatment of platinum-sensitive patients. Olaparib has been licensed in the United States for the maintenance of platinum sensitive and in Europe for the maintenance only of patients with BRCA mutation. And lastly, Rucaparib has been licensed only in the United States as a single agent for the treatment of active disease. Bevacizumab, on the contrary, is the only anti-angiogenic agent who received approval for the treatment of platinum-sensitive patients thanks to these two studies. The Ocean study simply reported that if you have bevacizumab to carboplatin gemcitabine chemotherapy in patients with platinum-sensitive recurrence, and then continue bevacizumab after stopping chemo, you are able to significantly increase progression-free survival of the patient. The GOG 2013 trial reported also that if you add bevacizumab to carboplatin paclitaxel, and then after stopping chemo, you continue bevacizumab, possibly you are able to increase also overall survival by 5 months. Overall survival was the primary endpoint of the second trial. Completely different the strategies of maintenance by PARP inhibitor. This is a pure strategies of maintenance. The NOVA trial addressed the use of Niraparib as maintenance treatment in patients with platinum-sensitive disease still responding to at least 4 cycles of carboplatin-based chemotherapy. At the end of chemo, patients in response, complete or partial response, were randomized 2-to-1 to receive Niraparib or placebo. 2 different and parallel cohorts of patients were enrolled. The G-BRCA patient, I mean patient with the mutation of BRCA, and the non-G-BRCA patient simply selected according to the clinical criteria of platinum sensitivity. In the second cohort, before the trial was closed, a next-generation sequencing, my choice, myriad test, were used in order to address if we were able to identify a so-called HRD-positive population able to respond to Niraparib. The trial had 3 primary endpoints. It wanted to address the efficacy of Niraparib in all the 3 mentioned populations. The trial was positive, but really it was a surprise for us to see that also in patients with HR-negative test, there was a percentage of patients, about 20–25%, who still experience an advantage in the use of Niraparib. This is why the drug was approved in the United States regardless any HRD test. But what is more important for me is one of the key secondary endpoints. This is exactly what we are looking for, something able to increase the chemotherapy-free interval for our patients. And Niraparib significantly improved this interval in both the cohorts. Just my last slide to underline that usually it's very difficult to have a cross comparison between trials. In this case, it's quite impossible, because the 2 strategies are not overlapping in the philosophy, but also in the way in which the progression-free survival was measured. If you look at data with bevacizumab, you will see that progression-free survival was measured since the beginning of chemotherapy treatment. If you look at data with the PARP inhibitor in general, you will see that the progression-free survival was measured at the end of chemo. And don't forget that that is a selected population according to the response to platinum, which means it is a better prognostic population. So in conclusion, ovarian cancer really remains one of the most lethal cancers, and unfortunately, treatment effectiveness declines with increasing line of chemo. When patients recur, that patient needs our help, because the watchful waiting strategies is not appropriate strategies for the patient. This is why maintenance treatment are really important, because they help patients to live well for a longer period of time without experiencing progression. PARP inhibitors have reported to be very useful strategies in the setting of maintenance. And finally, the primary result of NOVA, but I'm sure that Sven will give more details on this, have reported that Niraparib is an active agent able to significantly increase progression-free survival of our patients, and it's also well tolerated. Thank you so much.